Hello, everyone. I am Dr. Pamela Kryskow. It's a pleasure to be here with you all today. On behalf of the Psychedelic Association of Canada, I am one of the founding board members, and it's my privilege to be here today as your host. And to start off, I would like to acknowledge that I am uninvited guest on the unceded territory of the Cohuse First Nations, and it's an honor that I get to live, work, and play in this beautiful land in British Columbia. A few announcements before we move on into today's webinar. June 20th coming up is World Psychedelic Day, and we are hosting a networking event, the Psychedelic Association of Canada. So we'd love to have you come in and meet some of your friends, colleagues, and some of the Psychedelic Association of Canada board members will be there as well. And a nice little victory for all of you that signed the petition that we had, the federal e-petition in the House of Commons. We had a petition, as you know, that many of you know, that was asking our federal government to legalize psilocybin for anyone with end-of-life challenges and our palliative care diagnosis. And we hit the threshold number that was read in Parliament on May 15th. So for all of you that are just joining now, I'm Dr. Pamela Kryskow. I'm one of the board members of the Psychedelic Association of Canada. I want to say a great big thank you to all the volunteers that work with us at the Psychedelic Association of Canada. We actually have only 2 paid employees at the Psychedelic Association of Canada, and we have 30 plus amazing volunteers doing all sorts of great stuff for you. So loving that people are joining now. Feel free to put in the chat where you are from. We'd love to know where everyone's coming from. And if you have questions as we go through Dr. Robinson's presentation, put them in the Q&A, and we will be happy to answer them after he goes through his presentation. So again, welcome everyone to the Psychedelic Association of Canada, our presentation on eating disorders and psychedelics. And so in order to start on time, and so you guys can all get out there and enjoy a beautiful June evening, I'm going to hand it over to Dr. Robinson to do his own introduction and then move into the presentation. And I'll be back with you for Q&A after.
Thanks. Quick intro, then I'll share some slides. My name is Reid Robison. I'm a psychiatrist based in Utah, and my main role is as Chief Clinical Officer at Numinous, which is a Canadian company, but we have a network of clinics in Utah and Arizona, in addition to Canada. And so I started my career in academics at the University of Utah doing research, looking for new mental health treatments. I'm a clinical trialist by background, got a little frustrated with the state of treatment options in psychiatry. And that led me to the study of psychedelics, beginning with ketamine. My first ketamine study was about 12 years ago. I did an IV ketamine for depression study for Johnson & Johnson, and was really intrigued by this non-daily treatment option and by the non-ordinary state of consciousness that I got to sit with people during. And so that I wrote my first grant to study it in 2010, set up a ketamine infusion practice back then as well at Utah's biggest hospital. And that led to interest in other psychedelics. I went even to experience and volunteer at an ayahuasca retreat in the jungle in search of, specifically new eating disorder treatments. I was brought in by MAPS to be the coordinating investigator for the MDMA study for eating disorders a couple of years ago, and helped get that protocol through the FDA and Health Canada, and then helped to train the sites in both clinical trials and eating disorders, and currently supervise the clinicians at Numinous, and including the ketamine assisted therapy practices. We do work on some pilot programs like group ketamine work, and I'm principal investigator of a lot of psychedelic studies. We're currently doing a psilocybin study for Compass, my LSD study for MindMed. And I was just in fact, yesterday, a 12-hour LSD dosing session for one of those studies, and really enjoy getting hands-on with the work. And one more important point is that I grew up in Canada. So I'm a dual citizen. I'm born in Chicago, but raised in Ontario, from kindergarten through all of high school, living in Burlington, Ontario, but came out to Utah for college and stuck around. So it's good to be here with you. I will share my screen and let's talk about eating disorders. All right. Okay, first of all, because I'm sitting in a different place, I'd like to just acknowledge that I live and work in Utah, which is actually named after a tribe called the Ute tribe. And we are the traditional and ancestral homeland of 8 distinct tribal nations here. So I do this work with respect and really hope it will benefit the people of this land and the relationship with the origins and the indigenous peoples here. So one fun fact before I jump into some eating disorder background is the first psychedelic study that I'm aware of in a clinic was actually psilocybin for, well, there's a case report of psilocybin for anorexia from back in 1959. This was in Paris. It just so happened that after the trek down to Maria Sabina and psilocybin came to light, and Albert Hoffman kind of reverse engineered, figured out the chemical structure. There were some mycologists and chemists sharing this knowledge, and the chemistry and some of the compounds they were doing, and some psilocybin was sent to Paris. They were doing this study of a number of hospitalized psychiatric inpatients, and there was one case report that was really interesting of a 35-year-old woman with anorexia, hospitalized, and she was in the hospital. Basically, the treatment then was isolation and try and make them eat. And then the psilocybin study came along. She participated. It wasn't psychedelic therapy back then. It was like giving a medicine and seeing what happened. So the participants were actually taken from room to room, floor to floor, and subjected to some psychological interviews, tests. It seems a bit jarring. And the outcomes of these cases aren't that exciting because the dose was also half of what we're studying now, and the set and setting was, I mean, a little bit. The concept was non-existent, and the setting was a little bit troublesome, I think. But this individual, when she got her first psilocybin injection, that's how they gave it then. She saw a choir of angels and had this profound spiritual experience. And she didn't display much, kind of like my LSD study participant yesterday, a lot of internal work. And she didn't display much, but she did recount this experience and then change her behaviors immediately after. So they gave her another dose. A few days later, stopped her Thorazine that was probably interfering somewhat anyway. And then she made some profound steps towards recovery. The long-term recovery, there were some relapses and it's not totally followed up. And there's a lot left to learn about the right way of using these things. But I just wanted to share that there is a published case report from just a couple of years ago by Meg Spriggs and colleagues working in the eating disorder psychedelic space that I found really interesting. Whoops, I have to get that back online. So a little eating disorder background, and then we'll talk about psychedelics. But I've tried to summarize this initially on one slide so we can talk about some key points. That about 10% of people will experience an eating disorder in their lifetime. And eating disorders are mental health conditions with a few main categories of behavior, like patterns of behavior. There's restricting food intake. like eating very little. There's binge eating, rapidly consuming a large amount of food. And then there's purging, like eliminating calories through overexercise, vomiting, laxative, diuretics, etc. And so you have conditions like anorexia that are restricting and inability to maintain a minimally kind of viable, healthy weight. There's binge eating that is binging, and then there's bulimia that's the binging and purging. And there are a lot of qualifiers in the DSM, a lot of other conditions in the eating disorder category as well. But that's a bird's eye view summary, refresher. This may be kind of a repeat or well known to many of you, but a few other key points I wanted to highlight. Weight isn't the main factor here. You can have a normal weight, still have a serious eating disorder with serious health consequences like osteoporosis, electrolyte imbalances, anemia, cardiac, kidney failure, GI issues, et cetera, et cetera. So you can't diagnose or tell based on weight alone. And then also important is you can't get rid of an eating disorder by simply eating differently, because it's not about the food. It is and it isn't. The food is kind of a window to what's going on beneath the surface. So these are complex biopsychosocial conditions. And if you ask people what causes eating disorders, you'll get a lot of like, we don't know exact causes. That's because there isn't just one cause. And I've been working in the eating disorder field for quite some time. I didn't say in the bio that I've spent several years full-time as a medical director of a treatment facility out here in Utah. I'm still their medical director and really actively involved in the eating disorder space and in conferences. And I can't think of a single case over the years where there was a simple single cause, right? These are biopsychosocial, but at the core, eating disorders converge around this disruption in self-perception, with most people being severely self-critical. And eating becomes a tool to try and regain control over internal or external chaos. And there are, just like there are some genetic or temperament risk factors like perfectionism, there's also co-occurring mental health conditions. There's an increased rate of PTSD and trauma in general in individuals with eating disorders. There are co-occurring substance use disorders at very high rates. We'll get into a little of that with eating disorders, especially certain types like anorexia co-occurs with OCD more, an over-control type condition. Bulimia has some more loss of control features, co-occurs with more substance use disorders. Perfectionism, body image dissatisfaction, these are risk factors, red flags. Internalized weight stigma, I almost feel guilty using this term because I think it needs to be said in a more blunt way that a large part of the problem is society and our obsession with these beauty ideals that change the ages, the social media that we're bringing more and more habitually into our lives, and the exposure that does to young people, especially when they go searching out or become interested in body image, these beauty ideals. And then there is the oppression of women through the ages is another like serious problem feeding into the eating disorder epidemic, if you will. And we'll get into these in a little more detail, but there's also, if individuals are bullied, if they have early onset menses, if they participate in body focused sports, activities with peers like ballet, dance, cheers, long distance running, etc. These become risk factors. You could almost view it like the two-hit hypothesis of cancer, or you think of the saying, genetics loads the gun, environment pulls the trigger. That's what I see a lot, people with predisposition in their temperament and an unfortunate exposure to one or usually several different risk factors and life events that lead to this perfect storm. And so that's a broad summary. We'll dive in on some of those in more depth, but a few other kind of points I wanted to make from this eating disorder soapbox for a second is people don't choose disorders. You don't wake up and say, I'd like to have one. People do say that, celebrities, you probably heard it, but when they do, they're very misinformed because these are not choices, they're serious neurobiological illnesses. And the reason someone develops an eating disorder and then maintains it are very different. So you might engage in food or body related practices, behaviors for either innocent reasons or in response to stressful life events, or but before long, these things can become very deeply ingrained. And this is why they also be one of the reasons why they become very difficult to treat. So eating disorders become complex in that regard and require intensive treatment, especially when serious, and especially when there are recurring relapses. Think about someone with, say, bulimia, and there are these binge purge episodes. It's very hard. You can't just, as we know in the the mental health world, you can't just think yourself out of deeply ingrained patterns for the most part. But sometimes it takes going into a different environment. Sometimes it takes 24-hour care or day treatment for a period of time, a number of weeks, to interrupt the pattern. And we'll talk about how all of this, these eating disorder specific treatment considerations combine or may combine quite well with psychedelic medicine or psychedelic therapy. Ages ago, over the past several decades and intermittently, sometimes parents and families have been blamed for eating disorders. And I think that's very counterproductive. And even though, of course, your family of origin and your upbringing plays a role, and if your family's focused on diet culture in an extreme way, that might be one of the factors contributing. But families happen to be the number one ally for recovery, and therefore they become very, very important in the path forward. And involving loved ones in a good way can go so far in helping people heal. So, and then one last point is the symptoms, even from a transpersonal lens, can be very telling. There's often a symbolic nature to them, and it's not always about the food. It's not always about the hunger. There's often something deeper and something, some emptiness in the soul that we land on. And psychedelics and the therapies and approaches we pair with it are also a good match for this type of self-exploration. So just a fly through of how society has played a role and how these things have showed up through the ages. There were in ancient Rome purging rooms after feasts. May or may not have contributed, but some people, when they're exposed to eating disorder behaviors, they go beyond the point of no return and they get into troubled territory, whereas others bounce back. It's similar with substance use disorders and other conditions. For example, in African tribes, sometimes parents would starve themselves just to save food for the kids, but some of those parents, those who would be at risk, might become unable to resume eating and even die from it. There were a lot of religious influences through the ages and some really nice things written about it. I'll give an example here. Anorexia mirabilis, just a term for this miraculous lack of appetite or denying oneself of food for God. And there's a case that kind of explains this well. patron saint of Italy, who used starvation as a religious kind of discipline practice. And but interestingly, in her life, her sister died during childbirth when St. Catherine was 15. And then the parents tried to arrange for her to marry her sister's husband. And she fasted in protest, refused to marry. And after this fasting, she became really unable to ever exit that pattern and ended up dying of starvation at age 33. And so we'll fast forward to like 1770, for example. There's another example of someone at risk getting into these troubled territories of a Yale professor during a stressful time, studying 14 hours a day, sleeping 4 hours, decided food was a waste of time or dulled his intellect, started restricting. You could kind of see some obsessive compulsive traits here in the counting of mouthfuls, and we see the same things these days in caloric restrictions and weighing food, etc. But when his weight dropped to a certain point, he became seriously ill and stuck. And I also found it interesting that his doctor prescribed a bottle of wine, banned study, and miraculously for this individual, that worked. This way of interrupting the pattern. Let's see, this you may recognize in the bottom right. So there's Marilyn Monroe on the left, Twiggy in the 60s, and then things have just flip-flopped and progressed, and you have the Kardashians and this whole new era of what the internet and what people in our cultures consider beautiful, which the common theme here is this beauty ideal, whether it's thin or voluptuous or whatever era we're in, is completely unattainable and unrealistic by most people, and therefore the search is futile but persistent. And so we'll go ahead to some striking statistics of so there are eating disorders, and there are disordered eating behavior patterns and body image concerns, if you will, which over 50% of teen girls have engaged in what you could call disordered eating behavior patterns, like weight control methods. 60% or so diet regularly, and this becomes a risk factor in and of itself, because those who diet are 12 times more likely to engage in binge practices. And over a third of dieters progress to what you might call pathological dieting. But what gets really striking as a parent is seeing these statistics of, even in elementary school, 42% of first to third grade girls want to be thinner, 81% of 10-year-old, and I believe that was a female survey as well, are afraid of being fat. So the idea that no one escapes like childhood or their upbringing unscathed, one of the big risks we face as humans, and this is unfairly, disproportionately harder for women in our culture, and is the societal focus on appearance and the diet culture we're steeped in. And so this is what it looks like in terms of eating disorders. I drew a little Venn diagram that's not to scale, but I used to say 1% of women will get anorexia in their lifetime, but I've seen more recent estimates of in the 1% to 2% range. But when you add in all types of eating disorders, you get to about that 10% of Americans will develop an eating disorder in their lifetime. We talked about some of these risk factors, but I'll just point out the comorbid conditions where around over half of people with an eating disorder have co-occurring generalized anxiety. It's close to that number for a mood disorder as well. In bulimia and binge eating in particular, there are high rates of substance use disorders and somewhat in anorexia. And the last line shows that over 50% of people with eating disorder have a history of childhood trauma. And so on the nature versus nurture debate, I just have a stance that it's not a debate. It's always both, right? First of all, these are my twins, identical twin boys. Quite a while ago, they're now 14 and they're just in the other room, but this is, I just put it up for fun because these crib nets are now not available for purchase. I guess they got recalled, banned, not acceptable, but they came in handy back then. But as a parent of identical twins, it's really interesting to me to look at heritability and the heritability estimates of mental health conditions and other conditions are largely informed by twin studies, identical fraternal twins reared apart. But all of these mental health conditions land somewhere in that range of, say, 40% to 90% heritable, autism on the higher end, although there are hundreds of different genetic forms of autism. There is a large genetic component, and you see eating disorders up there, like many of the other mental health conditions in the 50-60+% range. And what that looks like is, say you're born with a temperament that predisposes you to anxiety, harm avoidance, perfectionism, drive for thinness, obsessive-driven personality, and that is what kind of the deck of cards that sets you up for what happens next. And if you have some of those other risk factors we were talking about, then it can turn into disordered eating behavior patterns and progress from there into full-blown eating disorders. So what's interesting and what's struck me for years about working with individuals with eating disorders is they are often some of the brightest and most accomplished and capable individuals you will meet. So these variants, these temperamental traits can be both a blessing and a curse, or they can be superpowers that turn into a maladaptive pattern and a deeply ingrained one sometimes. And one way to look at this is through, there's a pediatrician who made this highly sensitive child scale. So I'll just point out the survey, but there's this idea of dandelion children versus orchid children. Orchid children being highly sensitive to the environment and will only grow and flourish and thrive if the conditions are amenable to that, whereas dandelion children could grow through concrete, could survive in other circumstances, and they may not have some of that exquisite sensitivity, sixth sense intuition that comes along with the other side of the coin of some of these traits that can become troublesome. So and then there's this idea, and with the disclaimer that all flowers being beautifully equal, tulip children might be someone who falls in between. And so if you'd like to screenshot this, if the slides are shared, this will be in there, or you could Google highly sensitive child scale. If you're interested, there's also the cutoffs below if you want to do a quiz on your observation of your own children or friends and relatives. It's kind of interesting to look at, or reflect on how you were as a child. So let's forge ahead, and a quick little fly through of what's going on in the brain. When you woke up this morning and had breakfast, say you had a piece of toast, you take a bite, goes down to the gut, there's a signal up to the insula in the brain, registering, what it tastes like and how hungry you were. And you might say, okay, that tastes good. Your amygdala is just always monitoring. Anything wrong with the toast? Nope, keep on going. How about now? Nope, stay quiet. So the signal then travels down to the reward circuits, dopamine spike. You might put a little jam on it, some butter, get a bigger spike of dopamine. And meanwhile, you're taking bites. The front brain gets a little analytical. The amygdala isn't firing. You liked it. It tasted good. There's some pleasure. Let's keep on going. Your dorsolateral prefrontal cortex says this is good. More bites, more dopamine, more. Just keep on eating it. And the parietal lobe might say, "Oop, how do I look and feel in comparison? Am I dieting?" You might keep on going. You might stop before you're full or uncomfortable, or and then you look at someone next to you, say your loved one with an eating disorder who is just staring at their toast and will not eat it. And you just, like many parents or caregivers say, this tastes good, this is just toast, why can't they just eat it? But if someone with a full-blown eating disorder takes a bite of that toast, signal goes to the same parts of the brain, but no hunger registered in the insula, nothing, flatlined. That can be desensitized over time, like many of our body, many of our sensory processes. And so serotonin just passes on by. They might try taking a bite just to placate you, but after a bite or two, no, I'm not hungry. How could you not be hungry? Because that hunger has been desensitized, and they also don't like you looking at them while they're contemplating eating this. And so they might take another bite, tastes like cardboard. There's some amygdala alarm bells going off now because they're eating, they're not having a hunger signal. They don't want to be eating, nothing registers, no dopamine. Alarm bells start to fire more. You've got the caudate weighing in saying tastes bad, feels bad, maybe we should panic. Parietal lobe saying don't eat more of that, you're going to explode in size. And this can be overwhelming. It can be a full-blown panic situation. It can become a more like a fight or flight, a put down the fork and run instead of eating your toast. And that's one thing that makes eating disorder treatment and recovery very tricky. And I just have a few slides on traditional treatments of eating disorders, but wanted to give the disclaimer that the mainstays of treatment are behavioral and psychotherapeutic. And it's a very multidisciplinary treatment team. So in the eating disorder treatment center I work with, it's a combination of psychiatry, internal medicine or primary care, like eating disorder medical specialty, and dietitians. And then you have others collaborating as well. It can be long-term treatment. There might be education. There's rec therapy, movement practices, etc. But especially the dietary therapy and med psych collaborations are the norm. And there's a lot of work that's been done. There's some very effective psychotherapies for some types of eating disorders and some stages, but there is a very high rate of relapse and very serious consequences of eating disorders, especially anorexia and often other bulimia, binge eating, progressing to a serious category. So we do need a sense of urgency about how we approach this. Like if someone comes in and they're not menstruating and they're losing weight, but traditionally the medical profession and the insurance here in the US that would pay for visits would say, there's nothing wrong enough to warrant treatment, come back when things are worse. And this has always struck me. We never dream of saying that in cancer, like your cancer is only stage 1, come back when it's stage 2 or 3. But yet that's what happens all too often in eating disorders. And early intervention is so important, early recognition as well. In fact, we shouldn't even wait until the full medical workup and diagnostic workup is complete and crystal clear. Regardless of what that shows, the initial steps will probably land on the same thing of, initial weight restoration and therapies focused on restoring the eating to a more balanced and sustainable place. So the eating disorders, you probably often hear this, is that, anorexia has the highest mortality rate of any mental health condition, yet no FDA-approved medications to treat it. In anorexia, it often, early intervention helps, but whether it's early intervention and unsuccessful treatment with relapse, or catching it too late when things are pretty deeply ingrained, there's this 30 to 60% of people end up with what you could call severe enduring anorexia, chronic, which is the one with the highest mortality rate, and it becomes harder and harder to treat the more the brain gets starved, and the more the body kind of goes into this territory of malnutrition. So there is one medicine FDA approved for bulimia, that's Prozac. Binge eating disorder, more recently added to the eating disorder category several years ago, has one medicine approved, Vyvanse, CBT being the gold standard for binge eating disorder otherwise. We do use a variety of different medications in treating eating disorders, even anorexia, but they're targeting symptoms, and they're pushing the needle just a little bit in many people, like antidepressants for comorbid, anxiety or overlapping anxiety symptoms or obsessive symptoms, maybe mood stabilizers for the mood related stuff, and antipsychotics sometimes for the rigidity and even to spark some appetite or help with sleep. But needless to say, it's been severely lacking in terms of our treatment options. And one of the reasons why I went on this pursuit of studying psychedelic therapies for eating disorders. So one thing I wanted to point out is that because it pairs well with the psychedelic therapy world, is the goal after early weight restoration, seeing if someone can refrain from eating disorder behavior patterns enough to maintain a diet, plate themselves even, then we move towards these principles of intuitive eating and trying to reconnect with body signals, and treat food as fuel for your exploration of the world, instead of something you need to quickly purge or exercise away the caloric content, and learn to find a spark of like self-acceptance, self-compassion on the path to improving body image, and even that ideal of self-love that we talk about. So let's talk about psychedelics and why they might help. And I'll just check on our time here. Psychedelics can make eating disorder and interventions easier to receive for a couple of reasons. Let me see where this there. I skipped this slide. Through maybe two main ways. So the classic psychedelics and their serotonergic signaling and cognitive flexibility can make the patterns, these deeply ingrained, tricky patterns to treat, more malleable. Although we'll see this in some of the preliminary psychedelic research data in anorexia in a minute, that sometimes a higher dose might be needed, more therapy, more frequent dosing sessions. These are questions that we're faced with these days. And psychedelics also can bring about a brain state that can accelerate or catalyze the therapeutic process of these therapies that often either don't work fully or don't work in everyone, or someone is unable to engage in and make first steps towards, whether it's because of a fight or flight reaction when faced with eating, or because of a incessant like ruminative self-critical voice inside one's head, or other kind of variations on this that psychedelics might get in and help with in terms of pattern interrupting, psychological flexibility, self-awareness, connecting with a higher power, things like that. So there are some studies looking at, like this is out of Imperial College, of all the surveys they've done of people planning to take a psychedelic, go into different retreat ceremonies. They looked at some who reported having an eating disorder diagnosis and did see significant improvements in depression, well-being following the psychedelic experience in people with a history of eating disorder. So some early signals saying, maybe there's something there. And I put in this slide because when we were talking about how eating disorders develop over time, starting with maybe an attempt to control food intake because of body image concerns or because of traumatic events in life or a combination of all of these things. Over time, the sensory input like we get from our bodies and from the world gets deprioritized in eating disorders. Like the hunger signals become more and more distant or absent, and that intuitive eating is just so far from what's going on in the throes of an eating disorder. But when you have a medicine like a high dose of a classic psychedelic that comes in and relaxes the weight of these ingrained patterns and tightly held beliefs about the world and oneself, like heating up the brain under the influence of this medicine, making it more malleable plastic as the brain cools down, and we're reforming this hierarchy. That's when the eating disorder therapeutic interventions really become key during the integration, and maybe even in a more important way than with some other conditions where you can get out of the way of the process and let the medicine and the inner healer do its magic. Sometimes there's a lot of clearing needed to be done in eating disorders to make space for the inner healer, or it might be so far buried beneath some of these patterns. And so it's when you have a condition like anorexia, often co-occurs with OCD in 25 to 50% of people with anorexia. A condition of over control, you could see how relaxing these beliefs and these patterns can be an important step in treatment. And then in a similar vein, you're kind of boosting or reclaiming the importance of those bottom-up sensory inputs so you can move back towards those things like eating, living one's life in a more intuitive way. And so just a slight variation on the theme of what a course of treatment might look like is just the collaborative nature of this, and how if someone's going into a course of psychedelic assisted psychotherapy, the psychedelic team, the clinician, guide, integration professionals may or may not be informed in eating disorders. The more informed, the better. But there is still eating disorder specific therapy needed. So I always encourage that people have a dietitian on board and an eating disorder therapist on board when embarking on this, and ideally a consultation with their medical providers about any unique to eating disorders medical considerations that one might need to keep in mind when going into a dosing session. If someone is whether they're getting ready for MDMA therapy and they have cardiac concerns from a chronic eating disorder or electrolyte imbalances, or whether they're going off to the jungle to do ayahuasca and there's a concern around purging or the dietary preparation for that and what that might do in someone with an eating disorder, and all things that can be navigated, but they require some awareness and some special attention to these considerations. So let's see here. Let's talk about ketamine first of all. There was back in 98, I think was the first ketamine study, the only one for quite some time, at a treatment center where they gave 10-hour infusions of ketamine, 20 milligrams per hour, and this other medicine called nalmefene. And it was just a small kind of pilot open label. But they did show a decrease in compulsion scores with this interesting kind of dosing protocol they had. There have been some cases down here. The last couple on this list are our papers. One, just a review of what's out there and a discussion of the potential. But the last one on the list is a group ketamine paper that I'll show you in a moment that we published last year from work done at this eating disorder treatment center with groups of 4 doing weekly ketamine for 4 weeks. And then more papers, thankfully, are coming, more case reports, nothing large scale. This is the study I talked about. It was done at like a treatment center in Arizona back in the late 90s. Our group ketamine study, this is at Center for Change here in Utah, who I work with. And one of the, it's really a center that treats people from all over the world. People, some are from Utah, but many are from other parts of the USA. And from the people in 24-hour care, we recruited 4 at a time who seemed to be good candidates for a course of ketamine plus therapy. And we would do IM ketamine in a group setting once a week, and then some ketamine specific integration, but they also had their 2 or 3 times a week eating disorder therapist sessions, their dietary sessions multiple times a week, working with their dietitians, family therapy, et cetera, et cetera. And we tracked some outcomes, saw that both anxiety and depression scores decreased through the course of this. And it was a pilot program, not a randomized controlled trial, kind of more like an open label feasibility study. But I'll show a quote from one participant who said, "Trying ketamine let me see the possibility of a life I could have. While the effects did not last, sounds like ketamine, my first experience snapped me out of a state of lifelong deep disconnection that I didn't know I'd been experiencing. Suddenly I was able to live in the world the way people always described it. Though I'm still trying to figure out how to attain that level of connection after catching a glimpse. That one experience was so essential. I could finally feel hunger and fullness cues. I felt human for the first time in a long time. And in a way, the medicine was a way shower, like opened the door for this individual, gave them a glimpse of what's possible. And I've witnessed this countless times with individuals with eating disorders, whether it be with ketamine, S-ketamine, or other psychedelics when we've done studies or done retreat work with them abroad. Sometimes they get a glimpse of self-love that is also extremely memorable and embodied kind of experience of that gives them some hope to fuel the path forward. We also did a pilot study, not yet published, more of a formal study and more robust measures, doing an outpatient ketamine assisted therapy protocol. We brought in caregivers and did some emotion coaching as part of it. We did 3 ketamine dosing sessions, and then integration sessions with and without the caregiver, the support person, spouse, parent, loved one who's involved in their care. And this is small numbers because it was a self-funded study we did in numerous clinics, but we did see depression scores go down, anxiety scores go down, eating disorder overall, symptom burden go down. And this embodiment survey that I really like, out of Toronto, Neva Puran created this and wrote a great book, a textbook on it. But the experience of embodiment scores went up through the course of this study, like re-inhabiting one's body, and in terms of both joyful expression, pleasurable feelings, and then also just feeling grounded and safe in one's body, able to use one's voice, etc. So, oops. I think this, we'll move to MDMA next. So that's a brief summary of ketamine. We'll talk a little about MDMA, a little about psilocybin, and then we'll move into questions. This is from one of the MDMA studies from MAPS, who said, who happened to have eating disorder concerns as well as their PTSD. I'm tempted to say MDMA gave me hope, but that word isn't right. The insight was more substantive than hope. I'd held the sensation in my body. I understood at a visceral level what might someday be mine, the senses of peace and joy within my body. For me, the therapeutic process could unfurl from there. So as we know about MDMA, it's this very unique chemical compound that happens to increase trust, which is very important and challenging in eating disorders, because your treatment team is at some stages of the process viewed by the individual as the enemy, like the dietitian who wants you to eat when everything else inside you says do not eat, becomes a very difficult therapeutic alliance to navigate, but one I believe MDMA could help pave the way for. The fear reduction, there are studies showing the amygdala alarm bells going off excessively in eating disorders in response to food. And so you can see why MAPS has allocated resources and donations to study MDMA for eating disorders as an additional indication, because of what it might do in terms of fear reduction and the ability to move towards one's emotion. There is emotional avoidance, avoidance of negative emotion at the root of many eating disorders as well. And that ability to go back safely into one's body could, I believe, really be facilitated for some individuals with MDMA and the right kind of therapy. So that's what's kind of brought us to this place of beginning to explore it. And in combination with psychotherapy, we start to see how MDMA might enable the client to be in the state of safety and empathy when reflecting on self, instead of that self-critical default mode. And maybe for the first time in their lives, start to really be with their anxiety, fear, history of trauma, without the same kind of negative affect and emotional avoidance, and potentially even fight or flight that shows up intensely when one tries to do work on healing without these kinds of supports. So that's what led to this MAPS protocol I've just summarized here. It's called the Med1 study. That's looking at both anorexia and binge eating disorder. And one, it follows a similar protocol to the PTSD study, but also includes caregiver involvement. So participants need to have an identified caregiver who does some sessions with them. And you can see on the protocol there that there are 6 individual integration sessions, but 3 integration sessions that have individual and caregiver involvement. And I'm just a big fan and firm believer in families, loved ones, caregivers being some of the best allies for recovery, because when people come in to see their clinician for, say, psychotherapy once a week for an hour, or even if they're in some intensive outpatient a few hours a day, it has nothing on the number of hours they spend out there in the world and with people they live and interact with. And so if we can arm the people spending that much time around the client with an eating disorder with some tools and how to support in a good way, then the potential outcome, the potential benefits become exponential or at least enhanced. So this is a paper that Michael Mithofer and colleagues wrote up looking at MDMA-assisted therapy and eating disorder symptoms in the PTSD study. So there were 90, so 15% of the PTSD participants had a high score on what's called the EAT-26, a self-report eating disorder questionnaire, and 30+% had scores in at least a risky range. But after completing the study, there was a significant reduction, statistically significant reduction in their eating disorder psychopathology scores compared to placebo. And the I'll just leave it at that. More rationale for the study of these things. We did have to, while getting this study through the approval process, ethics and regulatory, this was a common question of what about MDMA and its effect on blood pressure, heart rate. And just like in the MAP studies where there's this kind of idea that if you can tolerate normal brisk exercise, you can tolerate MDMA in terms of the cardiac effects. But this is something to just pay extra close attention to in individuals with eating disorders who may present as like severely bradycardic, which is common in severe anorexia, or there may be the opposite, and there can certainly be a lot of fluctuations and postural hypotension, things like that occur with eating disorders. Not to mention what happens when you're purging, like with bulimia, severely purging, and your potassium can get extremely low. So let's talk about psilocybin lastly, and studies that are ongoing using psilocybin. Of course, less case reports out there other than that one I showed from the 50s because of the Schedule I nature. But thankfully, in my opinion, eating disorders have gotten kind of early attention as indications of importance, both due to the need and due to the potential goodness of fit with psychedelics and eating disorders. And I'll just summarize some of these, like the Imperial College study is doing 3 doses of psilocybin over a 6-week period for anorexia. And that one is well underway. They did these really nice focus groups beforehand to help design the study protocol that have also been published. And I put a quote here from one of them that helped inform how they designed this. There's a neuroimaging component. Compass funded an IIT, investigator-initiated study in San Diego. Walter K., who's been, and this one has completed, I believe, and their target was 10 individuals with anorexia, 1 dose of psilocybin. And here's some preliminary results that have been shared is, 30% had clinically significant reductions in their eating disorder symptoms after 1 month. That went up at 3 months, which is really interesting and kind of encouraging to see. There were less concerns about body shape at 1 month follow-up. 90% thought it was a meaningful and useful experience. No new, unexpected, surprising, or serious adverse events. And Walter K., eating disorder academic expert, said about the study, patients often hate their body shape and believe they're fat. Some of the patients in our trial reported a different positive view of their body image. The early results offer hope this treatment could be a breakthrough. At Hopkins, there's an anorexia study well underway as well, and some initial, this was presented, I think I heard a talk on this at not last year's Horizons, but 2 Decembers ago. And these are some things I gleaned from that is the subjective effects of psilocybin were kind of diminished compared to what would be expected or what would be typical in their studies, maybe related to malnutrition, some concurrent medication use that may have been allowed in the study, or other parts of the neurobiology of anorexia. And like we might expect, individuals with anorexia may require more therapy paired with it. And change in eating disorders does take time. It's like physical therapy after an injury. And so there is a binge eating disorder study with psilocybin by Tripp, and they had at least one patient that they reported on after dosing and some preliminary outcomes that showed reduced anxiety, including food-related, reduced impulsive or just a binge, and improved self-image. And so there's not much we can conclude, of course, from an N of 1, other than good case report data and positive steps along the way. And so taking a step back from the psychedelic world, just to talk about some overall aims of eating disorder treatment and how eating disorders not only affect all of us in one way or another because of their prevalence, but disordered eating and body dissatisfaction are concerns, in my opinion, for every human. You know, we all have work to do and maybe some awareness to shine on our relationship with food and body. And we as a culture need to continue shifting from like the body as an object, as the body as a home, and from a focus on weight to health, and from moving to get rid of calories to moving for pleasure, and see that the body is really meant to be your safe place, your resource, and not a problem to be solved. And yet we're steeped in this culture that prescribes diets, eating disorder symptoms, essentially for people at a higher weight. So there's this movement called Health at Any Size, HAES, HAES, that you can look up, that really strives to educate clinicians, especially in not being insensitive to this, and not kind of in weighing or body shaming in the wrong way when people come into clinic. And because the fact of the matter is, you don't need to know your weight to be happy or even to exist. And that's just one number, and when we take into equation, like in eating disorder treatment, but it's definitely not the focus. And so along come psychedelics, the return of psychedelics into kind of the mental health research and into society, which presents this promise and a new glimmer of hope for some innovation in eating disorders. And so I would consider psychedelics to be adjunctive, as a therapy aid, a catalyst to aid in making the therapy, like in kicking it off or making it easier to receive, or in accelerating it through some obstacles with increased flexibility and openness. While yes, they are generally safe and have a lot of advantages over traditional medication treatments, there are still unique medical and psychological things to keep in mind with eating disorders. But I've witnessed time and time again some very touching, inspiring progress in clients who have received these and gained some benefit, and I continue the pursuit, and I'm looking forward to discussing with you from your questions. Thanks for listening.
Reid, that was fantastic. Thank you. We have some great questions here in the in the Q&A. One actually goes right back to right at the very beginning of your talk, when your slide that said making sense of eating disorders. And you're talking about you can't tell based on weight alone. And one of the people watching asked, would the use of body mass index impact this as well? I find a lot of insurance agencies and healthcare providers still revert to BMI, body mass index, as an accurate means of evaluating health status.
Yeah, it's a really good question and topic of debate that rages on in the field. Kind of a necessary evil or a data point to use appropriately, with all these caveats that yes, it is useful to know weight. We used to, in fact, categorize eating disorders based on BMI, like severe anorexia had, meant a certain BMI because part of the diagnosis is inability to maintain a certain viable weight. And then bulimia would not have that, weight factor involved, and would often have the binge purge. So we measure it in a blinded way at treatment centers, encourage primary care offices to be more sensitive to the triggering nature of weight for more people than we think, and like to remember in clinical practice that there are a lot more numbers to factor in than just weight, and that's just one of them and not one of the most important ones. But yes, I do like BMI better than weight alone.
Wonderful, thanks. Heather asks if your clinic in Utah is accepting Canadians, so maybe we can post some contact information for your clinic.
Yeah. So you can email me at, you see my name on the screen or on the talk, REID dot ROBISON, my first dot last name at numinous.com. And we have had people fly in from Canada for a course of treatment with ketamine, for example, or people fly in for eating disorder treatment, specifically at treatment centers. But sometimes we'll do family, like intensive retreats for a family. I've even had people kind of fly in, like an adult child with an eating disorder, and both parents who were struggling with their own mental health concerns, both related to the serious illness in the family and their own struggles. So we gave the whole family ketamine and integrated and did family work, individual work, and had a great experience that way. But yeah, there's not an off-the-shelf offering this way, but I love to try and do whatever I can to help for individuals where other approaches have failed.
Thank you. Jacob would love to hear an extended tidbit on your thoughts on Vyvanse for binge eating disorders, namely at the low doses, 10 to 20 milligrams versus a high doses, 50 milligrams plus, and how these compare across different genders.
Yeah, stimulants are interesting in eating disorders because, yes, Vyvanse has been shown to be effective in reducing the number of binge eating episodes per week compared to placebo. CBT is still the gold standard, still beats Vyvanse if people can find it and really do it. The combination of both together hasn't really been studied because Shire did what it needed to do to get Vyvanse approved, and it's on the market and widely prescribed for ADHD and somewhat for binge eating disorder. Do other stimulants work as well? Probably. We don't really know because they didn't go through the process with the formal trials and FDA submission. There are dose equivalency charts. I always aim for the least effective dose, right? Like if someone can attain remission on 10 or 20 of Vyvanse rather than 70, amazing. and treat for the minimum amount of time while keeping in mind the risk of relapse and the consequences of that. But so Vyvanse is also interesting, and stimulants in general, because they're sometimes misused as an appetite suppressant in other eating disorders. Right? They're used, like you would have people with, there's even studies to show with anorexia and ADHD, it's more complicated. It's harder to treat the combination. And stimulants are just one piece of that puzzle. But when we're numbing out the appetite or suppressing it with the medicine, but really wanting it to return and guide our eating practices, it becomes opposing forces. So yeah, not sure if that answers the questions, but I just thought I'd ramble off some Vyvanse opinions. And thanks for asking.
Jamming on that one, there's another question sort of related. How could psilocybin or psychedelics help alleviate binge eating disordered eating, binge eating / disordered eating in those with ADHD? So the combination.
Yeah, with
ADHD there briefly.
Yeah, the ADHD, the with ADHD one is a trickier one to answer because yeah, there are these studies showing that ADHD can complicate the treatment and recovery of certain conditions like anorexia, but there's not a whole lot of data there. We don't really know, you know, what we're doing when treating multiple conditions at once. But there is some promise of psychedelics, some potential there of psychedelics at certain doses for both, right? There's some, you know, theoretical benefit for both psychedelics and both binge eating and ADHD. And even I'm thinking of, like in binge eating disorder, one of the therapeutic interventions I like to offer is trying to help people insert a pause between that stimulus and response of their stressor and or trigger, the activating event, and the beginning of a binge. Like whether that's even practically speaking, setting a timer and say, I will not do anything until this 15 minutes has passed, and then I'm going to go down my list of other things, you know, or even do something drastic, run the other way before I engage in a binge. Because in a binge eating disorder, a binge means a lot, right? There's a loss of control during, and there's feeling of discomfort and some other consequences after. So binge as a term is thrown around in different ways, but these can be really debilitating. So having some mindfulness training from psychedelics or some enhanced awareness and ability to interrupt patterns in the real world could go a long way. Combine that with, you know, if you had stimulants on board, you'd have to consider the impact there of like stimulants increase in heart rate, psilocybin bumping it up a little bit during a session, things like that. Are there other interferences we don't really know about? So yeah, I don't have a crystal clear answer for you, but you're bringing up some important questions.
On that note of what you said of having that pause, that is something we work with a lot with our patients in our program is you're going to the fridge, you're going to do it. It's not going to stop, but having that embodiment, that somatic practice of whether it is something like tapping EFT, whether it's 4-7-8 breath, that there's, and we're not, and patients are saying that doesn't create any anxiety because there's not a voice in their head saying you can't do this or this is bad. It's like, you can do this, but first this. And many times they start to, over time, go, suddenly they're now starting to connect with what's really coming up. And
it's a practice.
Bringing it back into, and it's still a control thing too, because you can that space.
No, I like that a lot, and it is important to remind people, I think, that these patterns didn't appear overnight and they won't be extinguished in one dose of a medicine. Even though there can be an awakening, there can be a new perspective, it still does take that continued attention to our behaviors and our patterns, especially out there in the world in the face of the triggers. So yeah, those practices you mentioned, I think, are a great example.
Heather is asking, where can one get this psychedelic therapy for eating disorders? You mentioned ketamine. This is legally available. Other than that, right now in clinical trials.
Yeah, so clinical trials are hard to come by, especially in eating disorders. The best I can answer is, in this time that more and more clinicians, including eating disorder professionals, are becoming trained in psychedelic medicine and ketamine work. But there are also more and more groups out there working with ketamine assisted therapy who would gladly collaborate with the team of eating disorder professionals, right? So like when people are stumped, I often encourage them, to kind of take matters into their own hands and see if they could cobble together a combination of the two, like a skilled ketamine therapy practitioner and their eating disorder clinician to collaborate and integrate things together. But there are even some eating disorder treatment centers, like the ketamine study we did here in Utah is an example, but I know ERC in Denver, for example, one of the top treatment centers, has also used ketamine on their units, along with all the regular therapy. And there are some retreats out there internationally. It's harder to vet, but some with varying degrees of eating disorder focus and expertise. But there's also equally large caveat of, being careful with going sight unseen to groups, especially with an eating disorder where there's a lot to be said about, being sensitive to diet and body concerns when immersed in a treatment setting.
There's a lot of questions here, by the way. I'm going to try to pull some more of them together, but this one is, you didn't really hit on this, and this is really interesting. Michelle asks, do you think that, two questions, that you had met Michelle at an ayahuasca retreat and where you ate all your meals with support and an aim to eat in terms of intuitive body eating and mindfulness. Do you think a psycholytic dose could support this experience as corrective? If so, what medicine would you suggest? I'll let you go with that.
Yeah, so that's a really interesting question. And hi, Michelle. It's great to hear from you. And so I love the idea of and the intervention of a corrective experience. I think we can do that in so many ways in the psychedelic medicine field, right? That includes just being good space holders that aren't running away from people's display of emotion and aren't projecting our shame and our own biases about the world on people, especially in that vulnerable state. And when in terms of eating, like you're bringing up a really important point in eating disorder treatment, an example of that collaborative nature where there's not just a dietitian on board, but the dietitian is often eating meals. Like there's a practice, there's a living the experience part of eating disorder treatment that is unique compared to other fields. And but to answer the question of what medicine might facilitate corrective experiences in eating disorders in particular, I think I don't really have an answer or way to differentiate the classic psychedelics. If someone were able to, in the right way, with all the legal disclaimers, access a low dose of psilocybin, a low dose of LSD, combined with the right therapies, might there be some acceleration, some enhancement of the corrective experience, some flexibility out of the equation? Yes. And would that happen with Wachuma or I've heard people anecdotally talk about healing their eating disorder with a low dose of ibogaine. I don't have any data on that, but I would love to see it studied, and think it's certainly worthy of studying. Like ibogaine, for seeing patterns, as difficult as that might be during the experience, could be quite useful.
I would imagine anything that can get at some seeds of some of the traumas is going to move people forward. But I
Yeah.
really like the idea of that lytic dose, where you're kind of in that heart opened space.
Mhm.
You can start to engage outside of some of the armor, perhaps.
Yeah.
It's intriguing. I really like that question. The second part of the question is, have you noticed a comorbidity of binge eating disorders and ADHD?
Yeah, there is some shared risk there in terms of impulse control. We talk about ADHD is a bit of a misnomer, just as a term, because it's really a lot of it involves executive functioning, and a lot of it involves impulsivity, much more than just attention. And there was also a failure to recognize the emotional dysregulation feature of ADHD for quite some time, that's now finally showing up in the assessments and scales. So yeah, I think there are some common factors there and shared risk, and maybe some of those could be treated together with the right therapeutic interventions.
Just scanning through here, so slightly distracted for a moment here. Do you want to talk about, there's a couple questions around any of the medicines, the psychedelics or ketamine, and interactions that people would want to be concerned about if they were going to be being treated. So
with ketamine in particular.
Let's see, there's a couple questions I'm trying to combine here. Sorry about that. One is risk of with psychedelic therapy, especially with SSRIs. So we know that there is some interaction.
Yeah.
So I'll let you answer that while I find the other one. So go ahead.
Yeah, so SSRIs, as I mentioned earlier, the only medicine approved for bulimia is an SSRI. And there's also, interestingly, a black box warning on Wellbutrin due to seizure risk because of a small finding with eating disorders. And it's at higher doses of Wellbutrin, you lower the seizure threshold. With bulimia in particular, you're worried about seizure risk and electrolyte imbalance. So there are those kind of considerations that play into it. But the SSRI question, I think, is the same in eating disorders as it is with say severe depression and psilocybin. It's to be determined how much they play a role, like in terms of interference or safety concerns. But I think they can be navigated, including with eating disorders. And I would say, especially with eating disorders, because these are conditions where the stakes are high, and I wouldn't want to rock the boat more than necessary by being like over conservative, by taking away some supports that may be helpful. So I would work even harder to try and find a path forward to clinically treat someone, even with some meds on board that may not be ideal, as long as they're safe. But with ketamine, I think the same. We do a lot of ketamine and eating disorder work, and Spravato for eating disorders with comorbid depression, and we just have the same medicine contraindication list. There's nothing new, just more attention paid to the overall medical screening a little bit.
We found it with psilocybin, and we found a huge variability in our program with our special access patients, that for some it doesn't matter, and some and some it's somewhere in between. So it's a curious area for research on what will be that factor that we finally figure out that goes, oh, okay, you're going to need a much higher dose, or we're not going to be able to overcome receptor occupancy here.
Yeah.
or you're good to go. You're going to do really well, because I've been tracking this for now for about 5 years and I can't find pattern yet.
Yeah, that's fascinating. And I think the eating disorder itself, I would guess, is more likely to interfere with subjective effects than an SSRI. That question mark, like you're saying, that's been a common theme that I've seen in ketamine work and in working with classic psychedelics too, is that there, with some eating disorders, there are walls of resistance that understandably, protective walls that can get in the way of the subjective effects. And sometimes that can be addressed potentially by more preparation, by higher dose, by more dosing sessions, but certainly worth being aware of. Yeah.
Another question here, which I really like a lot. MAPS has been told by the FDA that they when they finish their adults, they're going to need to go into young adults, into teens.
Yeah.
They're going to need to take it down the route to younger and younger people. And Liam asks, given the early onset aspect of eating disorders, what are your thoughts on the value of psychedelic interventions if and when these illnesses present themselves in childhood?
Yeah, it's a really good question, and I'm standing by with excitement, and even talking with MAPS about this adolescent MDMA study. I think yes, the FDA encourages it, and yes, they should, because lives could be saved from anorexia, for example, by intervening early. The question becomes who to do that with and how to access it. Even when I did my first ketamine for eating disorder study, the questions, my protocol at first said 18 and up. After going through kind of some discussion around ethics and clinical considerations, I had to raise that to 21 or higher, just because the conservative voices, which I respected and wanted an open dialogue on all this, felt like you should try traditional therapies first before embarking on something too experimental. But I would just add the disclaimer that there are people who are not getting help early and getting really stuck and ending up in a chronic, devastating place. And we should intervene as early as possible for those people. So practically speaking, in clinics, when some of the times we use ketamine for adolescents is for eating disorders, probably more common than other conditions, with a lot of family support and a lot of attention to the therapy. But I think it's an example where the stakes are high and the potential benefits outweigh the risk.
Yeah, that, I mean, it's a fantastic intervention with a really solid team, and saving a young person a lifetime of challenges in their families, and like you said, medical challenge that can also go hand in hand with that. So I really, it seems, and this transitions into another question I want to ask you, but this is really the value of publishing case reports and publishing. We always talk about the clinical trial, the gold standard, double-blind placebo-controlled trial, but there is so much value in the community stuff being published, these N of 1 studies, a case study, to move it forward. And then the question I really wanted to bring this to is, you talked about your pilot, this intramuscular study in group, when 4 people, versus like those people were probably quite a bit more unique and complex than if you had to do that clinical trial. And I think it's really important for everybody to realize that, like, when we go to these clinical trials, often it's one problem, one treatment, and in a pilot, you can actually treat a complex patient in a complex program.
It's which is more like the real world. And that's the one frustrating thing about doing sponsored psychedelic clinical trials, like the Compass study and the MindMed studies I mentioned. I love doing them, but it's sad to see so many people screen fail because of other conditions or other meds, when that's often just a signal of how much they need something, they need some help. So I'm with you 100% on we've increased our energy around getting case reports and case series and pilots published lately, because I think that's a phase we're in this field. Together we can contribute a lot.
Well, and one study that I won't name by name has spots for 10 to 20 participants. They've already gone through 1,000 applicants
Wow.
for a clinical trial. So they're not seeing our patients,
Yeah.
right? They're seeing your patients, they're not seeing my patients. So we need to keep that in mind. And the reason I stand on this soapbox just for a few moments is because it's really important for funders to understand this. We need funding in the communities too.
Yeah. Yeah, it's the clinical trials are a long-term play in terms of accessibility for sure. And like when people ask how to get into one, I don't have I don't know how to get someone into an MDMA clinical trial, right? There are these special access programs that are amazing, but there's so many people who need help beyond any of that, right?
Well, thanks for what you're doing. Thanks for enlightening us on all these routes. There's still questions, so that just tells us we have to have you back again.
Yeah, they're
Again,
great
because there's
questions.
a lot of really great questions, a lot more questions, and really thank you a lot for taking some time to be with us tonight and all the work you're doing. And people can follow Reid. I think we'll put some things in the chat box for you. Plus, this will be posted on our YouTube channel in a little while, so that you can watch it or share it with others. And again,
Cool.
I really want to thank all of our volunteers that really helped us do this. Thank you, Cheryl, in the background there, who's helping us. And you can find Reid in multiple places. Do you want to do a bit of a
Oh yeah,
how to get a hold of you and where to find you again?
yeah. Numinous.com. You can find me there, and our clinical work, research work, the podcast. And then yeah, you can find me on LinkedIn, Twitter as Reid Robison, Instagram, I think it's Inner Space Doctor, because Reid Robison wasn't available. But yeah, please reach out, keep in touch. Thanks for your questions. Thanks for having me. It's a fun group to spend time with.
And we'll get you back. Everyone have a wonderful evening. Go enjoy your Thursday.
Take care. Bye.
Bye-bye.